I think we'll make a start just after 12, and I'm sure people will join us as we continue. This session and any future sessions really informal, so there's no really strong agenda or fixed rules around this. This is about bringing together like-minded people in a community of practice, and how we start having conversations together across the country in terms of sharing some of our thinking or learning or whatever it is we're doing around reconditioning and the different parts of the world, the parts of the country that's taking place. So this session really is about asking you, mostly about asking you guys what you want from this kind of forum, and what can we do to help you, and what can we do to pull it together in a way that is meaningful and useful. And how's that going to help you guys moving forward, and what you want to get out of it. Previously, there's been some conversations around a particular topic around measurement that's come up on the WhatsApp group quite a bit, and in various conversations. So we're joined by Hayley Bishop from UH&M, Joe Macaulay and Mary Westlake from Nottingham, who are going to have a bit of a discussion around measurement a bit, and they got chance to ask questions maybe afterwards. The chat box is open, so please post some questions or thoughts or comments in there, and we'll pick those up as well and maybe fire those questions to the team. I know Hayley needs to get away after about half an hour, so we'll make sure that we try and fire as many questions to the team as possible before we lose them. Just so you know, we are recording. We always seem to record. I'm not even sure whether sometimes we do anything with the recordings, but we always record. So we are recording. So it is going to be available if anybody wants the recording afterwards, and I'll share that around this group and the group of invitees after this session. As this is the first one, I think this is an opportunity for us to collect, well, also particularly from ESI's perspective, is just to say just a huge thank you really to you and everybody and all the work that has been taking place and continuing to take place over the last 6 months and beyond. Really, I know, the reconditioning games really focused on the last 6 months. This is how we continue beyond that, but it's so important. It's such important work, and I think it's worth just. For me, I just want to say thank you for all the work that you're doing and continuing to rock up on sessions like this and have these conversations, because I think that's really important that we continue to connect with each other and continue to share and learn from each other as well. And I know Dr. Aurora wanted to say a few words as well. Amit, did you want to say a few words as well?
Yeah, thank you. I guess I'm only here to say thank you, because the amazing work that you've done over the last year or two, it's been absolutely astounding and inspirational. I'm kind of remembering back 2015 or so, when we first started to coin the term deconditioning in the clinical context as a syndrome. It was people asking, what does it actually mean? And then come back to fast forward 2023, when you see the porters and the dinner lady and the members of the public and the chief execs and the NHS England managers talking, oh, well, there are patients getting deconditioned, you know that you've done something good. And I think building on what Geraldine and colleagues did with the East of England deconditioning Winter Games, it's the amount of work that has gone in that one, as well as the reconditioning the nation, has been absolutely astounding. Through your work, we've kind of delivered 1,200 medals across 60 organizations, across 28 ICSs. Individuals, patients, families, they have felt better, and staff have felt better, because, as Geraldine says, you're bringing joy in the staff's everyday's work. I recently had the opportunity to judge for the HSJ Awards. This was, I think, earlier this week, or might have been last week. And there were two teams who presented the Recondition the Nation in their own hospitals. And the amount of appreciation that I got from the fellow judges. Of course, the teams did not realize that I was one of the judges, and I had abstained from the judging panel in terms of scoring, and I wasn't visible. But the way they were describing with the enthusiasm, the passion, the outcomes was absolutely amazing, and the fellow judges were equally impressed. So very well done to you all. And if you haven't applied for any of those awards, Nursing Times, RCN, BMJ, HSJ, etc., please do consider. If you need any help with those, I'm sure we will be able to find some kind of support. You've also developed 400 reconditioning ambassadors across the country, and they are quietly doing some of the work in their own patches without highlighting to others. And I've seen quite a lot of jobs in those kind of circles being advertised. My own hospital, Haley will tell you in a minute, have got, I think, 4 or 5 deconditioning diversional therapists. This morning I saw University Hospital of Coventry and Warwickshire. They have advertised deconditioning champions, and there have been similar roles elsewhere. But you also know, when you see the posters on the chief exec's offices, as we saw when we visited Norfolk and Norwich last week, and we saw lots of certificates on their walls which they were displaying with pride. So I think, colleagues, you have been absolutely amazing. You've done amazing work. It's been a huge success. I think the challenge remains of sustaining the progress, and that's what we are here for, as to what you want to do, how you want to do it, and what support can we provide to you. So thank you very much for all that you do. Thank you.
Thanks, Amir. Yeah, that's exactly that point about, how can we sustain some of this work? How can we, in terms of this community practice, how can we support each other in doing that? Just to lead us on to the first discussion with Joe, Haley, and Mary, then the context behind this is, and I'll let the guy, and obviously the guys will talk about this in a bit more detail, but the context was around that sustainability, about how do we demonstrate the work that we do in terms of those reconditioning activities. How do we show that it's making a difference, both from the patient perspective, from the staff's perspectives, but also from, people are thinking in terms of, well, it's all very nice, it's all very lovely that you do that, but you know what, we've got a hospital to run, and we need to make sure that we've got stuff being done. So how do we, it's not a term that I use lightly, but I'll use it anyway. But how do we get that return on investment in terms of the organisation? When we're short of staff, how do we demonstrate that this activity is worth doing, rather than just being nice to do? And I think, though, I'm probably speaking to the converted here, but how do we take that beyond this group who have enthusiasts? We recognise the work that we've done over the last, as Amit says, the last couple of years. People understand deconditioning and they recognise deconditioning, but it's almost, in some cases, it's nice to do if we can get around to doing that. Okay, so this is the conversation about how do we turn some of those compelling arguments, which go beyond just patient stories, because some people like a bit of data as well. We all like a bit of a different story to tell. So this is nothing particularly in terms of presentation, but it's a conversation that Haley, Joe, and Mary, I asked them if they wouldn't mind just leading that conversation, and then if any questions or observations or comments that as a wider group we want to chip into, then please pop in the chat box or pop your hands up, and we can start this debate, which will hopefully continue forward and maybe plant a few seeds in our minds as we go back to our bases to understand how can we bring measurement into the work that we're doing. So Haley, Joe, Mary, over to you. There's a little space now to fill however you want to fill it.
Hi, so Mary's kindly sharing the slides for us, and we're going to take it in turns to kind of talk. So this is us. So I'm from Nottingham University Hospital Trust. Mary and Haley.
So I'm Mary, I'm from NUH, I'm also from the University of Nottingham, and my PhD is funded by the National Rehabilitation Centre. Can everyone let me know if you can see the slides? Because I can't see them for me. Excellent, thank you.
Yeah, and I'm Haley Bishop. I'm the Head of Operations for Medicine and Urgent Care at UHM, but have a huge passion at the moment around frailty due to some of the work that I've been involved in recently.
Hang on, we're having technical difficulties. Here we go. We've gone too far now. There we are.
So, what we think is really important in measuring is to involve your patients from the very beginning. So, engage with your PPG or your patient involvement groups, get their help in defining and designing what the problem and the study that you want to do. Use them as a sounding board. They'll often be able to point out things that you haven't thought about. Get them to help sing the song in different forums. So locally in Nottingham, we have a very passionate patient involvement group representative who has been really instrumental in helping us shape audits and helping us report on those to the board. She sits in lots of different places across the system, and she really sort of sells the story of deconditioning and the importance of the projects that we're doing. And I think that's really important to help shape a project. And we also think that obviously we need to get patients involved in giving us the information, in getting involved in the data collection, in helping us make a survey, for example. So if you're making a survey, get patients to check it out, make sure that they are happy with how it's formatted. If you're doing an audit, get patients to shape what sort of data you're going to collect and how much you're going to collect and how you're going to collect it. And then get their feedback from doing the work as well. So always involve some patient feedback in whatever format that looks like. Next slide.
Okay. So I'm kind of here to talk about what is deconditioning, and I'm going to look a bit silly compared to Dr. Aurora, who has just said everyone knows what it is. So I'm doing a PhD project at the moment. I'm looking at how healthcare professionals recognise and respond to hospital-acquired deconditioning. It's a 3-year study. I'm just coming up to the end of my 2nd year, and so I've run some focus groups and some interviews and some observations and had a good look at the literature. So there's a bit of an evolution in terms of how we're defining deconditioning in the literature, from simply physiological changes that are induced by lack of activity and can be reversed, to thinking about functional decline that occurs during hospitalization that's unrelated to the injury or illness, and it can't be related to that specific neurological or orthopedic insult. We're then moving into 2022, looking at it as a post-hospital syndrome, so picking it up after hospitalization, getting bigger again, thinking about including physical, emotional, cognitive, social conditions, interfering with independence or quality of life. And just an extra couple here about talking about what is functional decline. Is it self-care skills, or is it a transient period of vulnerability? So almost more moving on to that frailty side of things. So while there's quite a lot of debate within the literature as to what it actually is, the common theme is you're looking at a negative change in a person's ability having been in hospital. Okay, and it's about pulling things together. So as I say, I've spoken to a number of healthcare professionals from different backgrounds, different professional groups, and it's thinking that people are much more than the condition that they come in with. So if we're going to recognise hospital-acquired deconditioning, we need to think about, actually, people are saying different things when they say hospital-acquired deconditioning. So when you're designing your measurement and what you want to assess, what are you saying when you're saying that you're measuring deconditioning? Because you've got professional groups like nurses using it in a very behavioural sense of the term, that patients need to be deconditioned from a higher level of support, and that's looking at their transition from things like ITU down to a base ward. You have people talking about having their life limited because of the length of stay, thinking about cognitive deconditioning as well as that physical deconditioning, but also that confidence, that resilience, that loss of problem-solving ability. Are you talking about new packages of care, increased packages of care, new equipment? So there's lots of different things that are being pulled together. And I just want to take a moment here to think, we're in a unique position with the new integrated care systems. We can collaborate over different systems and think about what impact our practices in hospital are having across a person's lifespan and trajectory. again, there's commonalities. So people are seeing unnecessary decline, whatever that may be. There's a sense of frustration. There's a sense that they're losing control over what they can control. And just remember that phrase. If the only tool you have is a hammer, everything might look like a nail. So from that physio perspective, we might see the mobility and think people just need to get out of bed more. But if you're really worried about falls or someone being confused, your hammer might be to cohort them, to restrict their movement. The same for kind of speech and language. If you see someone coughing while they're eating, you might make them nil by mouth. What impact is that going to have for their nutrition and their diet? And psychologically, you know, seeing people coming and going, just something to bear in mind. I'll get off my soapbox now. Oops. There we go. On to you, Hayley.
Yeah, so your why is always really, really important when you're starting any piece of work, particularly when we're looking at patients, because depending on your why will change what data you want to collect. And I think the most important thing is about there is so much noise in data. There is so many different things we can capture and reasons we capture it. And actually, it's really, really important to say, actually, what is the measure? What is the metric that's going to show me what I'm doing is making a difference? We all have different priorities. You know, NHS England's priority at the moment, urgent emergency care recovery plan letter came out, but actually one of the top recommendations is frailty. And we're all sitting here knowing that actually that is a huge reason why length of stay is increasing and why urgent emergency care is struggling. So I think it is about everybody has a different view. Everybody has a different professional group. Some people want patient stories. Others might want data and hard data to show something. But often we have so much noise that we might not hit the target right where we thought we did. So actually, I think it's really important. Falls is a really good example. You know, measuring falls reduction, wonderful, but actually, were they witnessed or unwitnessed falls? Because actually, if you look at it, you want to see an increase in witnessed falls. That's your real motivator, because that's what means everybody's getting out of bed and we're moving our patients around. So actually, some of the data does miss the point, and I think we need to reflect that as we move forward with deconditioning.
We're just going to take one slide back because my computer jumped, and we're going to go back to Joe.
Hello. So it ties in well anyway. So in terms of making a definition about the study itself, you need to look at who's leading. Is it being led by a patient involvement group? Is it being led by a professional group? Is it being led by the ICS? Who is looking at the data gathering and what is their perspective? So as Hayley said, there could be a lot of noise in data. It's about kind of trying to define what the aim is, and that will be defined in some senses by who is leading the project. Then it's, do they have enough resources? Do they have enough people, equipment, time and space to do what they want to do? So are they, do we have people from enough kind of levels? Do we have people with enough influence? Is everybody aware? And when I talk about people with influence, that could be everybody from an HCA on a ward through to somebody from the exec through to a commissioner. It's the people who are going to influence whatever you're going to measure. So if you're measuring something very ward-based, the HCA might be the most important person. If you're going to measure something around kind of discharge and function after discharge, then you might need to get somebody from the ICS to help you. Making sure that everybody's aware. So capturing your widest group of stakeholders, doing your stakeholder analysis, working out who's engaged and who isn't engaged, and how you can get involvement from those people who have got high power, through to how you can inform those people who have got a high level of interest and a high level of power but little influence over what you're doing directly. Yeah, that's my who's involved. Sorry, skip forward to.
Sorry. My computer is a bit leggy, which kind of reads quite nicely into this. So don't forget, it's the importance of two views. If you only get one view, you might see one set of data, but actually if you look at it from another professional perspective, look at it from a carer perspective, family perspective, you might see something different. So just being mindful. With that in mind, oh, that's going to load. It's talking about, so what parts of deconditioning do you want to measure? So really key thing, there's lots of different parts. So you can measure things like your bodily systems. You can look on a FEES, so a fibroscopic evaluation of your swallow, and you can see the wasting in the muscular wall and the back of the throat where people have deconditioned from not using that swallowing activity. You can measure muscle strength, you can measure someone's change in cardiovascular fitness. However, I'm going to go out on a limb here and say we're largely more concerned with those secondary effects. So how it actually impacts on that person, whether or not they can get out of bed by themselves, whether or not they can walk to the toilet, are they having falls, are they getting delirious? Those are probably the things that we're more interested in. And again, collaborating within the ICS, that person doesn't exist in a vacuum just because they're in a hospital. They have loved ones, they have friends, they have hobbies, they have passions, they have traumas that they've brought into hospital that we need to be mindful of. And thinking about the life course here, it's difficult to tie exactly what happens in hospital to what happens long term. But there's a really nice long-term study where they've looked at changing in activity behaviours in hospital, and actually a year later, even in our younger cohorts, they haven't returned to the same level of physical activity that they were doing before they came into hospital. So again, thinking long term, we don't just see people in a hospital as patients and their condition, thinking what effect might that have, what these care practices have long term. And if you're looking for a specific deconditioning tool, they said they don't exist. I would encourage you to have a look at the paper by Gordon in 2019, which talks about 8 different tools. The tug test is the one came out as the most recommended, but again, that doesn't tell us anything about someone's swallow or their mood or their diet or their connections to the social community. So take with a grain of salt. And then it's about setting your parameters. So thinking, once you've decided on what part of deconditioning you want to look at, does the size of the change matter? Does it need to be a big change? Does it need to happen across a certain a certain length of time? And you are best to understand your local context. So it's looking at who's in your local population, what characteristics do they have, what are the public health concerns, perhaps the social health concerns of that area, because that's going to be feeding in as well. So on to Hayley and Joe.
So we collect a lot of data already, and we collect a lot of information. And I think for me, it's about thinking about what do you already have in your organisation. There's a list of things there on the left, but actually there's hundreds of other things that we collect from our patients on a daily basis, a weekly basis, a monthly basis. Sometimes we look at it just on admission, but do we look at it again on discharge? And some things we only look at on discharge. It's about where we're storing this information. What method have we got? Is this digital? Is this paper? We record lots of things in different places within healthcare and social care. And I think it is very much about how reliable is our source of information and how has it been captured? And as Joe said earlier, by whom? Because that is really important. Actually, can we interpret this data? Does this data actually tell us what we need to find out? And actually, how useful is that data? And I think there is a lot of noise, as we said before, but some of this is hugely important for the patient. And clinical trial scores is right at the top. We often look at that on admission, and then we say, well, what were they like 2 weeks before admission? But do we ever do it again on the day of discharge? And actually then when they come in and they readmit, and it could be 12 months later, we have no baseline because we didn't do it on discharge, we only did it on their last admission. And what value would that give us? It may give us absolutely nothing, but it might give us something. And do we share those? We collect a lot of information, but how well do we share that with our partners and our integrated care teams?
Yeah, absolutely. And we're doing a bit of work between our trust in Nottingham and Hayley's trust in the North Midlands around how we gather information, what we gather, and how we can possibly analyse all of that. So in Nottingham, we get a lot of digital information. We use an online platform. We have assessments that take place every day or every few days or on admission or on discharge, and it's how we can pull that all together and turn it into something meaningful. And I know that in the North Midlands you're doing lots of tendable audits and you're looking at lots of more paper data, but you're looking at how you can use that in practice and what that will, and pulling it into dashboards and things and looking at how it can influence practice. So we're trying to learn from each other as trusts, and we're trying to think about how we can correlate that against some kind of a shared agreement around what deconditioning means, because we acknowledge the point raised by Mary earlier that there is no clear definition. So it's about trying to make a bit of an agreement and then trying to measure against that agreement. And I suppose look at some of the harm stuff. So there's an appetite to to address deconditioning as a harm event, and look at how we can use what we're already gathering to evidence that it is causing harm to people, as a bit of a way of raising the profile, firstly, and also as a bit of a way of, I guess, challenging some of the dialogue around staying in bed being safer than getting out and falling. Yeah. Thanks, Mary.
Okay, and again, just following on from that, so it's thinking about putting those findings in your local context and what you want to do with this information afterwards. So thinking about the difference between correlation and causation. If it's dry, hot weather, you'll see an increase in consumption of ice cream, and you'll also see an increase in the rate of sunburn. But eating more ice cream does not result in more sunburn. Just be mindful. I think Hayley makes a really good point about witnessed versus unwitnessed falls. Your total fall rate has gone up, but your unwitnessed fall rate has gone down, and that's the bit that you're really interested in. Okay. And also just thinking about your population, what changes did you anticipate anyway for that group, so that you're not making a rod for your own back? So for example, with hip fracture, people who come in with a hip fracture, you're going to expect that their mobility will be worse. They've broken their hip. There's not really a value in putting a benchmark and saying, well, they came in independent and now they're walking with crutches, so we've deconditioned them. You haven't. They've broken their hip, they have an orthopedic injury. That's kind of an expected outcome. So just be mindful of your local context. What did you expect for that population? What is a greater than expected decline in their function? And that's a really open conversation with all your staff groups. So thinking of everyone that could be involved in that patient care. That might be your domestic staff, but have a chat with them about their family. They might be withdrawing. The domestics might see that, whereas maybe some of our professional groups don't have the space or the capacity to have those conversations. So think about other resources you can also access. We're going to go back to Hayley and Joe.
Yeah, so how we use those results is quite important to us, isn't it? Because actually the reason we're all invested in this is we're trying to improve our patient outcomes, the experience our patients have, the experience their relatives have when they're in our care, but also help us develop business cases for the future. So actually investment in the right skills, the right workforce for the future. And again, for UH&M, part of it was around our entry to the John Hopkins programme, the American John Hopkins programme. And because actually, it's about having that international research, working with research about how do we measure deconditioning, and then actually how do we measure our success that we're having, and how do we show our teams how fantastic they are, because actually they are, and they're doing a huge amount of really positive work. Just a couple of examples. Joe's is on the left and mine's on the right, but actually, for us, it was around actually the lack of mental stimulation that we were giving to our patients on the ward was our area of concern. Our solution was a new role, but actually there was a lot of challenge to get that investment for that new role. But actually, what about our environment, the physical environment that our patients are in, and how do we use that environment was also quite key to us. But actually, a lot of hard work went in, a lot of support went into us. But actually, the results have been incredible. Therapeutic observations are down by 50% and 58% reduction in unwitnessed falls. And that's the key, isn't it? Actually, we weren't looking at falls, we were looking at unwitnessed falls. And actually, changing that one word in a data set does change the meaning and the outcome of what people's expectations were of that role. But actually, we know that we've improved the nutritional intake of our patients on a ward, and we have brought down length of stay in that particular area as well. But actually, we talk about sustainability, don't we? And actually, it is about those next steps. It's about sustainability. We proved something in one small area, and as Amit said right, we now have diversional therapists for all our older adult wards. So we can make a small change by looking at one or two single metrics, investing in it, working with the teams, and actually getting that support then for expansion of that to give us a sustainable workforce to support reconditioning in the future.
Yeah, and our example is that it came from the PPG. So our patient involvement group came to us with a problem, saying that patients were saying that they weren't doing enough, that they wanted to do more, that they spent a lot of time in bed and chair. So they wanted, as we know, they wanted to do bed and chair exercises. So we co-produced a leaflet, and we've introduced volunteers to support with this. So we're using our local students, we're kind of engaging with local sports science students, with local physiotherapy students, and students from local colleges who want to get onto medicine, for example. And we're training them up to do the exercises with patients. So on our first ward, about 44% of patients are being supported with the exercises. The patients are giving us some positive feedback about how they've been going. And we actually haven't had any impact on fall, negative or positive. So the falls have remained static, so we haven't increased them, which is what one of the worries was when we first started. We haven't decreased them either, but that's fine, isn't it? And what we have found is that the variation of patients sitting out has decreased. So prior to our intervention, there were either a lot of patients sitting out or hardly anyone sitting out, and now there's kind of a medium amount of people sitting out all the time. So we are seeing changes in how staff are behaving in terms of getting patients out of bed for meals, for example. Thank you, Mary.
Okay, and so we're on to a bit of a summary. So thinking about your key points from today, start with your patient and carer engagement. What's important to them around the conditioning? They will point out blind spots that you just hadn't thought about, and that's not criticism. That's a really positive allied relationship. So who's wanting the data? That's going to inform with their priorities around what type of data gets measured. Why are you measuring it? What's your problem area? Do you want to see a change in your falls rate? Do you want to see a change in the amount of packages of care that are going out? Do you want to see a change in your length of stay? Do you want to see a change in your patient's mood when they leave hospital? Where are you going to measure it? Are you going to measure it at the start? How often are you going to follow it up? Are you going to check in 6 weeks' time and see if things have changed? What are you going to measure? So thinking again, are you going to be specific? Are you going to measure bodily systems and muscle strength, swallowability, pressure injuries, secondaries to falls, injury, delirium, or your kind of your life course effects? And again, who's doing this measuring? We're all incredibly busy at the moment. We're all incredibly under pressure to just do. Adding this, you need to make sure it is the right place. Do they have the right qualifications? Have we invested in the right systems? And can they make sense of that data? Is it going to give you the information that you actually want? You're going to get a signal from the noise. What do you have? What do you have already? Don't reinvent the wheel. There's loads of stuff that's already been collected as routine data set. Can you get something from that? Will something in there be a proxy, a suitable proxy for what you're actually looking at? And again, that final closing point, think of the bigger picture. Don't get stuck in hitting the target and missing the point. Sitting out patients is great, but it's another sedentary behaviour. Just be mindful of that. Yeah, and we've just got a last slide as our resources slide. So any questions? Thank you so much for your time. Thank you to Hayley and Joe for doing the practical stuff. I very much sit in a lab and theorise.
No, thank you. I think that's really interesting and some thought-provoking comments there as well. I think the whole point is about how we start to stimulate the conversation, and if you're able to share those slides, if you're willing to, that'd be great, and we can circulate that around. That'd be amazing. So any questions? Anybody's got to pop your hands up, pop it in the chat while people are thinking and mulling over some questions. Just an observation or a point as well. I think the thing about the measurement, as you said, Mary, was around who's doing it and where. I think is so important. And what we see from a measurement for improvement perspective is we often try and leap from 0 to maximum, to get to that we just start and we try and fix something. I think it's important to recognise that we're heading in the right direction, or even just staying still sometimes is okay. So if we've, as Joe was alluding to before, sometimes we introduce an activity, and if things have stayed the same, that's a good thing, because we haven't shown that we've had a negative effect. So it's really important that we know, and going back to a previous point I think Hayley made, we know what we're measuring and it's meaningful, and that there's a point to it, but in a way which is, we understand that we are heading in the right direction. We know where we're heading. We know where we want to get, and it may take us a number of months, maybe longer, to get there. But are we heading in the right direction? And for me, from an improvement perspective, that's really important, just to know as a team that we are heading in the right direction. Any questions for the team on anything that they've thought of during their presentation? Joe, do you want to come in?
I've just realised we managed to get all the way through without mentioning SPC charts, and I don't quite know how we missed that out of our thinking, but because we had thought about it. So one of the things we also do is kind of gather our...
Yeah, it's been a really good presentation.
I can hear somebody. I don't know if you can still hear me. So one of the things we do is obviously look at our 25 points of data before we make a change, and then look at our 25 points of data in alignment with the QSA principles, and develop SPC charts to see if we have made a quantitative change to whatever we're measuring. So, for example, we might look at percentage of patients who have fallen, and look at that, which is what we've done in terms of an SPC chart. We might look at percentage of patients sat out, although as Mary says it's a problematic measure. It is something that's commonly used, so we might look at that and see whether that's having a change over time. So yeah, apologies.
No, it's a good point, and I think the if you're not familiar with SPC charts, that's fine as well. I think a simple run chart is as easy way to plot points on a graph and you join the lines up, and if you can do that on your departmental notice boards, and something as simple as that sometimes is showing the, you can show the progression. If you have got the skills and the people around you who can produce SPC as well, obviously it does give better information around trends and variations. That's more positive. But even if it's some simple like simple run charts is really easy as well. Deb.
It's a brilliant presentation. Thank you, everybody. I was just going to ask, have any of you managed to influence your quality dashboards or your quality rounds to start to collect some organisational data that's starting to support conversations with exec colleagues and senior colleagues within your organisations?
So this is something we're starting to do in Nottingham. This is one of the things we're talking to North Midlands about in terms of how we're going to do it. The exec are very keen that we start to do it, and our chief nurse is very keen that we start to do it. It's just looking at the data sets that we already have and working out how we can pull them into something that looks meaningful. So, for example, under our manual handling assessment, we have a lot of mobility information. Under our continence assessments, we have information there. We have information under our pressure and our skin integrity assessments. So it's looking at how we can kind of pull that all into a dashboard to take to board and to kind of have a safety metric about it. So it's very much a work in progress for our trust. I think Hayley's probably a bit further on with it.
I think I would echo everything Joe's just said. I think our chief nurse is very passionate about this particular topic, and has been for some time. And I think there are some absolute key metrics. Continence is one of them. Pressure damage is one of them. Medication errors is another one. There's some really key ones that she is very focused on, and that's where our tendable audits are focused now within the organisation. And obviously, she was extremely passionate about us joining the Johns Hopkins University research pilot with America. So we will have an app web-based tool which will be is piloted on a number of wards, but all of our wards are elderly care geriatrician led wards particularly, but not just there. It's also looking at our orthopaedic wards, so we'll be looking at a comparator across orthopaedics and medicine around the management of reconditioning and deconditioning as well. So Anne-Marie is very passionate about it, is very driven, and that's why we're working in partnership with Nottingham, because we have different tools. We'll be collecting similar information. Let's see what that looks like within the two organisations, and can we create something jointly that can be recommended as a way forward, because we're probably a little bit further ahead than some organisations, not everybody, but some organisations in our way of thinking. And Nottingham's even further ahead because everything's electronic over there, so it's even better. There's no paper, whereas I have paper still to deal with at Stoke.
Brilliant, thank you so much.
That's really helpful. I mean, to recognise that point that your organisation, Nottingham, will be further forward than others, but you always started somewhere. You started this journey at some point, and some people on the call today may be a bit further back, but it's about just finding a way. And appreciating that when you've got a chief nurse on board, or you've got a senior leader on board who's passionate, it does make things a little bit easier. Not every organisation may have that right now, but it's part of this conversation is how can we start to make that a thing and bring people in. We can't necessarily duplicate Anne-Marie everywhere across the country as much as we'd love to, because her passion is infectious, but it's about how can we start to raise some of those conversations. The final point for me, and again, other people chip in if you wish. The final for me is that, like a lot of your reconditioning activities, you just started with something. You just tried something to start off with, and it's exactly the same with measurement. You're not going to get necessarily the perfect electronic system which is collecting the right data for you. Sometimes it may just be manual data collection to start off with, and just try something, give it a go. All the things that Hayley and Joe shared before on that slide, all the metrics that they may think about or collect, some of those will work, some of them won't work, some of them may be applicable, some of them won't be applicable. The point of this is try something out, experiment, use those plan, do, study, act cycles in the same way that you would do with your reconditioning activity. It's the same with data collection. Sometimes it just doesn't work, you know, and you think, you know what, that would have been nice if we could have collected that data, but it doesn't work. There may be electronic systems that can pull that data for you, but there isn't always, and don't rely on, just because you can't press a button to run a report, it may be a little bit of localized, individual, manual, observational data collection. So hopefully that's been helpful in just stimulating a little bit of thinking in terms of what you may take back. As I said, try something out, and this is something I'd like to see continue and evolve and grow as the way that it has done at UH&M and Nottingham and other places as well. That have a look in the comments, but the chat box as well. There's a few examples that people are putting in there as well, which is really helpful. I think this is something that's going to continue to grow as we go on. So I hope that's been helpful. The rest of the session today, however long it takes, we're going to run through a short Mentimeter poll with you. This is about asking your opinion and your thoughts on what you want this session to look like, these sessions to look like moving forward. This is for you. This is your forum. We're setting this up on your behalf and to see what would be helpful for you. Thanks, Hayley. I know you've got to shoot off. So I'm going to hand over to my colleagues, Zoe and Emma, who are going to run us through a short Menti poll. I'm going to share my screen so you've got the details and you can log in as we do the introductions. Hopefully that should be on your screen now. You can scan the QR code if you've got a smartphone, or there's a login there if you've got a PC. We'd like to get as many of your views as possible, so there are currently 47 people on the call, so we'd like to get sort of near those kind of response levels in terms of, we really want to hear from you guys around what it's really important we know what you want. It's really, we could put something on and it really isn't what you want at all. So Zoe, Emma, over to you. I'll drive the slides for you.
Thank you, Nick. And as Nick says, we really want to get your feedback, because this ambassador forum will be for you. So actually it's, you know, we've already seen how much there's, you know, huge amount of shared learning and passion, but a real variation across the country. So if you've got your phones ready, you can scan the QR code, and let's go on to the next slide, which is the first question. Nick, please.
Okay, no problem.
So this is about kind of really your views. So what do you feel that this forum it should really focus on? And you can either kind of type that you agree or disagree. Oh, wow.
I was not expecting that reaction.
I think that's reflective of the passion and the motivation for everybody on the call, and some of the comments that have gone into the chat box. It's great, isn't it, that people actually want the forum. Changing okay.
So we've got 22 people have commented. So it's a little 24 little thing in the corner there. You can see that, so we can see what the kind of response is. And that's a really positive response. I recognise we are speaking to the converted here, but just in terms of the broader perspectives as well. So under your perspectives really is that, do we still see it as a priority, high priority as it used to be, and that levels of understanding. So yeah, really interesting to see particularly the last point there about the high levels of understanding. And I think that's that variation that we see, that what we see from Mary in terms of the literature and what we, you know, I think, and then where we recognise the conversations are growing. I still think, yeah, there's what that reflects is there still shows there's still more we can do around awareness around deconditioning. So 29 people, 30. So I think we're getting to the point now where we can probably, if we move on to the next question, Zoe?
Yeah, I think that's it. Fair feedback. Yeah, okay.
Cool. It should stay on anyway. People can respond to that.
And if people could feel free, please, just to pop your hands up if you want to get involved in the conversation, because this is co-creation. So we really, really want to hear anything that doesn't fit into the answer for a question that you'd like to share.
So this is about how we design and help to facilitate and help you design the forum, and what would you like from it? These were just some suggestions. So the next question will be any other suggestion. That's yeah, the learning and sharing is really important, isn't it? We've already discussed this already from what's already happening in Nottingham and Stoke. Wow. It's quite interesting to see it fluctuating, isn't it, when you actually think about what section. These were some suggestions. Obviously, we've had keynote speakers in the learning and action events already, but I think that initiates that conversation, that thought-provoking process.
And it doesn't have to be one or the other.
No.
I think what we've said here is that we can have a blended approach, but we just wanted to get a sense of what you wanted, a sort of mixture of, really, and what was more important for you guys. So clearly what this is showing that there is a higher degree you want to learn and share, and I think that's possibly that staying true to the community of practice principles. I think that's probably a fair reflection. As Zoe said, we will come on to the next one in a minute. If you've got those two people have said other, then you'll get your chance to put that in as well.
I think the learning and sharing is really important, isn't it? Because if you do have an organisation that has developed something that we can then reproduce and share and not reinvent for other, that works for other organisations, it's not one size fits all. But I think that that's a really good way of promoting and moving forward, because a lot of the comments in the chat about it's taken a lot of time to get people engaged and, you know, and buy in. So none of this happens overnight. So I think that's really important. So that's 30 feedback suggestions. Should we move on to the next slide? Because hopefully that's free text. So
yeah, it's a bit of free text. So yeah, this is the other question. If there's anything else that you think would be helpful in terms of this session, just pop that in that box there. Just building on what Zoe said, as people type in this, it's recognizing that there are a lot of people on this call and beyond who are passionate individuals about this subject, who may not have the community around them in their own organizations. And what we wanted to create with this kind of community practice was a sense of there are other people who think the way that you do and are in the same boat as you are, and then you can connect with those people and get a community and connect with your tribe beyond your organization. So that continued sharing and learning clearly reflects that, particularly if you are one of those lone voices in your own organizations that's driving this. Yeah, so sharing of resources, I think that's a really good point as well. Yeah, so I think we all have a role to play there in sharing. I'll see quite a bit of that on the WhatsApp group, and I'll put the link to the WhatsApp group in the chat in a moment if you haven't already joined. But that happens quite a bit, where people share documents and job descriptions and so on and so forth.
It's moved down. Can we scroll up, Nick? Because there was a couple of good suggestions about, yeah, look, sharing tools and resources.
Just while we're on this bit, and you've got free text to put in your ideas, it would be really good in this to think big, because if we are actually going to be a national movement and really make a difference, then, you know, as well as these really important micro actions, in my head, I foresee a Reconditioning the Nation conference, you know, or training events and things like that. But I may be thinking too big, and maybe that's not what everyone wants. But go to your extremes of what you want on this, so we can get really good ideas.
More badges. I've actually just this week I've run out of badges, so I may need to order some more. So there you go. More badges. Okay, that's great. Yes to conferences. Yeah. Yeah,
this
the
virtual world is fabulous because, you know, I'm sitting here in London and we're all meeting together wherever we are, but there really is nothing like actually making human connection with people, especially when you're trying to do something like this, you know, which is about hearts and minds as well as, you know, data and all the rest of it.
So just picking up on this point, these 2 points here, I think I'll have already, Brian. There's very much a collaboration between the movements, and this is all of the, obviously the underlying principle here is about reconditioning and reducing deconditioning, and we've always been supportive of each other. You know, this massively builds on the work of PJ Paralysis, and we are definitely, and I've said it many times before, but standing on the shoulders of giants here in terms of the work of Brian Dolan and many others. So I think this is about how we almost like start coming together now. And I see some people on the call. I'm not going to name names and pick on them, but I see some people on the call who have done a huge amount of work with PJ Paralysis, and that's the thing in their organisation, and that's great. You know, they weren't necessarily involved in the reconditioning games, but they're passionate about reconditioning, about reducing deconditioning. So this, for me, a lot of this forum is to bring together all those movements, whatever they are, you know, under different banners. So I think there's a huge opportunity to bring that together and start having some of those different conversations. I think the point of the Global Summit was that it's online because you can tap into different time zones at different points in the 36 hours. But clearly, might be an appetite for something different. Bigger badges, okay, noted on the bigger badges front. Okay,
that's really important, actually, isn't it? Because especially if we're trying to be inclusive and work collaboratively with our patients and they can't read what it says in the badge. It was a very good point.
Absolutely. So moving on, Zoe, sorry.
Yes, so I suppose this slide was about what would not be helpful. So what do we not need? I bet somebody's going to put more badges on this one, but I think we will collate these kind of responses actually and feedback. So there's quite a lot of other comments on the previous one. So this is just free text. So what do you not want to see? What have we done before? What do you not think would benefit? So this is just really a bit of a focus about what we can help to avoid.
This one's often a difficult question to answer, but we asked the question purposefully because sometimes we can just do things and make massive assumptions, and it isn't what people want. So we asked that question purposely to provocatively ask, you know, what would be a complete waste of time if we did it.
I was more polite than you, Nick.
That's just me from the Black Country. We're a bit more blunt in the Black Country. Yeah, that point there about, you know, sometimes sharing the things that haven't worked so we can learn from that. I think that's a really interesting point. You know, repeating the same stuff. Yeah, that's accessible. Yeah, I mean, we can signpost, I guess. That may be useful more than just representing again.
Yeah, that's really a good point there about only presenting success stories, because there's more learning sometimes from things that haven't worked. And I think that one of the statements on the previous slide was about how can we try and implement when we're so busy, we have staffing challenges, all the other operational and patient experience challenges within the current kind of NHS. So I think that's a really valid point, actually. Okay.
Yeah, we'll come on to timings again in a minute, but not necessarily times of the day. So I think that's a really important point that somebody's made there about the times of the day. I think, you know, we're never going to satisfy everybody all the time. It's finding a suitable time. So again, we can be flexible around that. And I think I don't think we've got a Menti question that asks specifically what time of day, but that may be something that we can follow up on in terms of where do you think it would be a helpful time of the day. And we don't want to eat into your personal time, but we want to make it accessible as much as possible. Okay. So move us on then.
Yeah, so this is just really practical, couple of slides on a couple of questions about really practical. How often do you want to meet as an ambassador network forum? So just one vote, and then the next question will be about the frequency, how often?
So should we do the frequency one first, because the frequency will dictate the duration? Does that make sense?
We can. I can move that on to the frequency first, then we can go back to the other one.
You go. How often do you think we should meet as an ambassador network? Oh, that was okay. Love seeing it how it switches around. Look, yellow and red switching around.
One of the things I'm always mindful of is that we don't always do create other environments as well. And one of the things, I think one of the questions which may come up later is about what else other than the forum, what else could we do to maintain some connection? So it's not so much all about this, which is where the WhatsApp group may be helpful, or it may be other things as well. That's really interesting and helpful to get a flavour or feel from what you think. We don't want to overdo it, but we want to make sure there remains some kind of momentum.
Yeah, we need to get a balance, don't we, to make it meaningful. And it may well be that people will be doing things within their own kind of regions, trusts, etc. But this will be a session where they kind of feed back their progress and learning. Okay, let's every 2 months and quarterly have come out on top there. So let's go back to how long the duration do we think the meeting should just be scheduled for?
This is a real challenge, really, in terms of wanting to make sure that we make it meaningful and not rushed, but not drag on and feel like we're taking up too much of your time, and being able to share some of have those conversations with each other. And you know, particularly if you want to do that sharing and learning, sometimes it is about getting the right balance between time and commitment. So looks like 90 minutes feels about right for the majority.
Emma made a good point earlier on, because she said if you attend a 90-minute meeting and you do get some time back, it's quite exciting to get a little bit of extra time back in your day. So
you've outed me, Zoe. I love that.
It's so true, though.
It's true.
It's true. It is true.
It's so true. Okay. Thank
so
you.
We've done that one. Move that one on. Okay.
This was just an extra question about any future topics or anything else that you'd like to see or suggest for the forum in the future, really, that we haven't already discussed. This was just a free text box, although we've already had quite a lot of suggestions already, so thank you.
Good, thank you. Yeah, these are good. Yeah, we can. Job roles, I think, is one that's been coming up on WhatsApp more recently. So that's a really good. That's something I think is really interesting, and the various job descriptions that possibly are out there and roles that places have.
There was also a comment there, Nick, about data, about the SPC charts, and that's definitely something that we could cover. I think even people that know how to use them can always do with a refresh. It's not the easiest. So anything to do with data interpretation or analysis. Yeah,
we can definitely do that. I think just measurement in general is using data for improvement rather than data for performance or judgment is important. Brilliant. I like all these. Thank you.
Business cases as well. Absolutely.
So much of this, because this is, I mean, we're facilitating this, but for much of this, we'll be putting the ask out in terms of the group to say, you know, this has come up. Does anybody have any opportunities, like we have done today with Mary, Joe, and Hayley? You guys are probably, well, almost certainly the experts in a number of these things, and there'll be pockets out there where there's gaps. We can go out and try and find and search for other people. But I think in terms of the forum, we'll almost certainly educate each other. So I think there's something about how we can tap into the resources that we've already got accessible to us. Mary.
A lot of these responses around kind of professionally shifting, so getting engagement from frontline staff, hopefully some of the work that I'm doing in this PhD will generate some of that.
Yeah, very much so. Thank you.
I think that's a really good point about how to publish findings and avenues to share and celebrate for kind of national awards, because we mentioned that earlier on. But actually, if you're really busy and overwhelmed within your current position role, within whether you're, you know, primary or secondary care, the great work's happening, but you don't know how to access that. So, you know, how do you enter your team for Nursing Times Award, etc. So actually, I think that would be, you know, that's really valuable feedback, actually. Thank you. So I think there was one more question, wasn't there? Anything else,
Yeah.
Slide?
Sorry, I was distracted by the chat then for a minute. I was just putting the WhatsApp group link in the chat. So this one was literally just anything else that you think that we haven't covered already in the questions, completely open, maybe nothing. We may have absolutely nailed it, or we may have completely missed the point. Is there anything else that you think would be, that you want to comment on, or points you want to make about the Ambassador Forum and how you want it to run going forward? And just, yeah, while you type in, I'll just drop the WhatsApp group link in the chat if anybody wants to join that. And again, that's for you guys. That's to use as you want to, and make the best use of as much as you want.
Can I ask that people pop into the chat where they're from? It's for pure interest reasons to see what cover we've got across the trusts and organisations. Thank you.
So the regional ambassadors one, an interesting one, and again, you may start to coalesce. You form your own smaller groups that may end up meeting more regularly. I know there is a Southwest, for anybody in the Southwest, there is a Southwest ambassadors group meeting. I think that's taking place next week. That's been led by Joe Jones. I don't know if Joe's on the call today or has been on the call today. This is a really informal network, and the Reconditioning Nation work has always been an informal social movement. So we've never established frameworks and leads. We've got Deb and Geraldine from the East of England as well, which continue to drive the work forward there. So, you know, there's still some regional activities, connections happening, but if it's not formalised, then bring it together yourself. I know there's evolving work in the Southeast. With a few people there in the Northeast as well, so that there's work happening. So you may just want to connect with people within your areas. Team Recon. I never thought that was going to happen. That's our slogan, is it? I think somebody mentioned having a slogan before. Keep at it, Team Recon. I think that's everybody here. Brilliant.
Okay. Thank you. We will collate some of this information and review it, and then obviously perhaps book a meeting for from your feedback, or the duration and the length of time. One question actually wasn't on there was what time of day actually. So obviously that might be something that we can address via email or have a conversation about, because that's a really important perspective. So thank you for that information. We will get back to you with some of the results, and there you go, Emma. Lots of people putting in the chat where they're from. It's great to see, actually. Thank you.
Thanks, guys. That's really helpful, and thank you for everybody for contributing to that. That's really informative. Helps us, and we'll start to set the form up based on that. The first few going forward. What I'll probably do is I'll ping out a poll or something that you can fill in relating to the time of day. Which will follow up on this, just to get some feedback on that. Any other questions that you may have? I think the chat tends to stay live even after the call, so if you think of something afterwards, just pop it in the chat or get in touch with myself, Emma or Zoe. More than happy to sort of pick those queries up. If you leave the call and think, oh, I forgot to ask that. I think there's a question I just saw scrolling by about connecting with the Southwest network, I'll pick that up and I'll connect you with Joe in the Southwest, so you can link up together. In using Emma's words, we've designed this so we may be able to give you some time back. So we finished a little bit earlier, and that enables you to use the time however you want. Go for a cup of tea,
go for a walk.
Go for a walk, whatever you feel you might need to do in the 25 minutes, 24 minutes, 23 minutes actually now that you've got back. Just want to thank you for your time today. It's been really helpful. I hope you found it useful and interesting, particularly around the measurement side. Thank you to Mary, Joe, and to Hayley for leading that session. We'll continue these conversations again, and I think this is the start of something where we can continue as a community. Invite other people. This is not a closed shop. Bring more people in as we grow. We'd like to grow. I think we've got 500 registered ambassadors, but I know there are more people who are connected to the network as well. So as the invites come out, please share them with other colleagues as well, and we'll bring in a greater community of practice. And remember, this is a national community of practice, so you are connecting with people all over the country, which is really helpful. If there's nothing else, I'm going to wrap things up.